Okay, why don't we get going? Hi, everybody. I'm Scott Burris from Temple University in Philadelphia, where it's raining and we don't have a safe drug consumption site. I'm happy to welcome a team of people from British Columbia who are going to be talking about legal and intervention practice and policing issues around drug overdose. We have with us Jessica Xavier, Zara Mandani, and Amity Mehta, who are all researchers at the British Columbia Center for Disease Control, as well as Mike Knott and Tracy Scott, who are peer workers in overdose settings in BC. Each speaker will have about 10 minutes, or each presentation will be about 10 minutes of the three. So we hope we'll have some time after the three sessions for your questions and comments. Please also feel free to use the chat to talk to panelists and to each other and to pose questions as we go along. And so we'll have a double layer of multitasked enjoyment of the session. So without further ado, I'm going to turn this over to Jessica and ask her to begin her session.
Hi, everyone. Happy to be here with you today. So I'll be presenting today on behalf of a larger team. So Dr. Greer, Dr. Crabtree, Sarah Ferenz, and Dr. Buxton. And I'll be presenting on our findings around police officers' attitudes, knowledge, and implementation around the Good Samaritan Drug Overdose Act. And I'm Jessica Xavier. I'm a research coordinator for the Good Samaritan Drug Overdose Act evaluation study here at the BC Center for Disease Control. Next slide, please. So just a bit of background about the Good Samaritan Drug Overdose Act. So similar legislations exist in different jurisdictions, but essentially the idea behind the legislation is to encourage people to call 911 in the event of an overdose by protecting legal protection for arrest around simple possession and conditions related to simple possession. So you'll see here some materials around the Good Samaritan Drug Overdose Act. Like I said, it offers legal protection to anyone at the scene of an overdose for simple possession and conditions. It doesn't extend legal protection for things like drug trafficking, offenses other than simple possession, outstanding warrants, and conditions for things other than simple possession.
You've accidentally muted yourself, Jessica.
Oh, sorry about that. So just a bit of context about why we needed the GSDOA. So here in BC, a public health emergency was declared in 2016 due to the overdose crisis. And research shows that often overdoses occur in the presence of a bystander, and also that bystanders hesitate or avoid calling 911 due to concerns around police involvement and arrests. So in response to this concern, the GSDOA was enacted federally, but it's unclear if now 3 years later, because it was enacted in 2017, if it's having the impact it was intended to have, and it's being implemented by police officers. Next slide, please. So on this slide, this is a bit of an overview of the evaluation project. So I won't go into too much detail, but just to point out that what I'll be presenting today is a component of a larger study, and other components were presented yesterday at the conference. But today I'll be presenting on findings from our interviews with police officers. So the research question that guided our data collection and analysis was, what are police officers' views, knowledge, and implementation around the GSDOA and responding to 911 calls? So we conducted qualitative interviews across British Columbia, and these were semi-structured qualitative interviews, and then that data was analyzed according to a thematic analysis. And so we used open coding to build a coding framework. And it was a really iterative and collaborative process between a team of researchers. We heard from 22 police officers. And again, this was, so you'll see a map here. This was across British Columbia in some metropolitan areas, large urban, medium urban areas. And this is classified based on a system we have here that is follows the definitions of Statistics Canada. And we heard from 19 males, 3 females, ages ranged from 30 to 51, and experience levels in policing ranged from 1.5 years to 28 years in policing. So one of the things we were interested in was what are police officers' views of the GSDOA, and are they generally supportive of the legislation? And what we found is that there was no consensus among officers about whether the GSDOA was having the intended impact. So we heard from some police officers that they were really supportive of having this in writing and having legislation that they can point to. So I think one officer described it as having to play to the lowest denominator. So having the idea of having this on paper being a good thing for officers who may have pursued arrests at simple possession before the act was enacted. And then there were police officers who believed that the GSDOA was not doing enough in terms of addressing the opioid crisis. And I won't read through the quotes, but I'll leave it to you to read through. But you'll see here that one of the participants said, the petulant person in me thinks that it's something that sounds really good for a politician who's looking for a way to solve the problem. In our research question, one of the main topics we were interested in was what are police officers' awareness of the GSDOA, but also their understanding and their knowledge of when it applies and for who it applies. And what we found is that the extent of police officers' knowledge really varied. So while many officers were aware broadly that there was a shift to view overdose events as from a medical lens versus a law enforcement lens, when asked to define the GSDOA, many weren't able to define when it applies and for who it applies. So for example, some police officers provided the definition of Good Samaritan acts, which have to do with liabilities around being protected for liabilities around responding to a medical event, which is different than the Good Samaritan Drug Overdose Act. Some police officers weren't aware that it protects more than the person overdosing, so bystanders as well, the person calling. So there was really a range in terms of understanding and knowledge. And then we asked police officers how they had heard of the GSDOA, if they were aware of it. And many police officers reported hearing about the GSDOA through email, and there were concerns around this method of disseminating new acts, specifically that this information could be overlooked, and police officers shared that they were inundated with emails, which I think a lot of us can relate to. So this was a concern. One of the large thematic categories that came up was interpretation and use of discretion with the GSDOA. And here, when we refer to discretion, it's the idea of police officers having the ability to choose how, when, and to what extent they enforce laws. So I'll start off by saying many police officers were in favor of having discretion and using a discretionary approach. Many saw it as being able to have a tailored approach to different situations based on their discretion. And discretion kind of showed up on a spectrum. So some police officers shared that they would use their discretion before the GSDOA was enacted to choose not to pursue a simple possession arrest. So using their discretion to take less punitive approaches before the GSDOA. And on the other end of the spectrum, some police officers describe using their discretion to determine what is the line, or what is considered the overdose setting according to the GSDOA, and when do law enforcement activities resume. And in this context, police officers shared when they would pursue an arrest at an overdose event. And so we heard things like police officers being able to find someone after an overdose and pursue arrest. Police officers just choosing to pursue arrest when someone became combative. So sort of seeing that as the end of the overdose setting and the beginning of a second phase or a new setting. Discussion also came up in the context of drug trafficking, and I'll just remind folks that drug trafficking isn't, legal protection isn't afforded to people when it comes to drug trafficking under the GSDOA. But the ways that discussion came up was, although drug trafficking is not covered by the GSDOA, there were mixed opinions about whether it's appropriate or appropriate to pursue drug trafficking arrests at an overdose event. So some officers thought it was, whereas other officers thought it was unlikely or inappropriate to pursue drug trafficking arrests at an overdose event. The other way that discretion around drug trafficking came up was around determining what is an intent to traffic versus simple possession. So here in Canada, there is no threshold amount. So police officers shared that it is based on their discretion that they would decide whether something is considered an intent to traffic. And finally, we heard about other law enforcement activities at overdose events occurring that are outside of the scope of the GSDOA. So other than arrests, things like seizing drugs, running names, and checking in identification, searching people, were all things that we heard from police officers that were occurring. And this is interesting as police officers recognize because these activities could potentially discourage people from calling 911 and undermine the goal of the GSDOA. So there are a few implications and recommendations based on these findings. So first off, more GSDOA education is needed, and definitely through mediums other than email communication. So leveraging adult learning principles and more active and engaging learning and making sure that that information is transferred to police officers. The other recommendation is more research is needed to determine rates of arrests at overdose events before and after GSDOA implementation. So like I mentioned, we heard from some police officers that this act, or not arresting for simple possession, was being enacted in everyday practice even before the act was enacted. And so it would be good to understand whether that is the case, and as a result, the act isn't having the intended impact, or if this has to do with something else, such as social desirability bias. And the other thing I'll point out is, as you heard, discretion results in inconsistent applications of the GSDOA, and this could give rise to skepticism around the GSDOA. So particularly for people who use drugs who may be learning about the GSDOA through their interactions at overdose events, inconsistent applications could reduce trust in the GSDOA legislation.
Jessica, can I ask you to conclude now, please?
Yep. Thanks. So that brings me to the end of the presentation. I'm not sure if we'll leave the questions till the end, it sounds like.
Yes, we'll do questions at the end.
Okay. And so here you can visit a few pages if you're interested in learning more about the study. And I'm happy to connect with folks if they want to chat about any of the findings or have any questions. Thanks, everyone.
Thanks very much. That's really another addition to the complicated picture of evidence on Good Samaritan laws. Now we turn to Zara Mamdani, Tracy Scott, and Mike Knott, who are going to talk about what you see right before you on your screen. So take it away, Mike, Tracy, and Zara.
Thank you so much, Scott, for the kind introduction. I am Zara Mamdani. I'm the project manager for the peer-to-peer project at the BC Center for Disease Control. And my co-presenters here are Mike Knott and Tracy Scott, who are both peer workers at their respective sites. So I'll just get started. As you may know, illicit drug overdose is the leading cause of unintentional death in BC. And we are currently in the midst of dual public health emergencies here in BC. The first, which was declared in 2016 in response to the unprecedented rise in illicit drug toxicity deaths, and the second one, which was recently declared about last year due to the COVID-19 pandemic. The onset of the COVID-19 pandemic has really compounded the impact of the overdose crisis for people who use substances. And since March 2020, when the physical distancing measures were implemented, the number of drug toxicity deaths have been on the rise. In fact, in July 2020, 175 suspected illicit drug toxicity deaths were reported, which is the highest ever recorded in a month in BC.
Peer workers are often affected by the opioid crisis. These are individuals that have lived experience with substance use and incorporate lived experience into their professional work. Peer workers are at the forefront of the overdose response activities, and they perform a variety of roles, including distribution of harm reduction supplies, peer witnessing of drug use, referrals to services such as housing agencies, advocacy, outreach work, overdose response, and research. In the advent of COVID-19, it has led to a reduced hours and closure of several overdose prevention services. And this further increased the importance of peer workers who are involved in outreach and mobile overdose response.
Mike? Mike, are you muted?
Okay, Mike, you're muted, so we can't hear you. We can't unmute you. You've got to find the mute button on your screen and...
There we go.
There you
Okay.
go.
I'm sorry about that. I'm not sure why that happened. We all know that working in an overdose response environment can be overwhelming and stressful, with lasting social, mental, and emotional impacts. Being a peer worker can be doubly stressful because we don't only face the trauma of others, but also face the same factors that affect all people who use substances, such as stigma, low income, and lack of support. However, unlike other first responders, we lack organizational and mental health supports from our organizations. It is super important to understand supports needed by peer workers and implement these supports and programs for us in overdose response settings. The peer-to-peer project, funded by Health Canada, is aimed at developing, implementing, and evaluating models and strategies to support peer workers who are working in BC overdose response environments. The project is being piloted by two organizations, Rain City Housing in the Lower Mainland and Solid Outreach in Victoria. Tracy is a peer worker at Rain City Housing in Maple Ridge, and I am with Solid Outreach in Victoria.
So the first step of our project included conducting a needs assessment. This was done through 8 focus groups with our pilot sites, and we found several important findings from these focus groups. These could be categorized into 3 different themes, and it formed the basis for our intervention model titled ROSE. The R stands for recognition of peer work, the O stands for organizational support, and S stands for skill development. The E emphasizes that the resources are for everyone. In today's presentation, we will focus on the R component of the intervention. One of the top stressors that emerged from the focus group data is lack of recognition and respect for peer workers. Several peer workers felt that they were not taken seriously or given due respect by their work colleagues and by other professionals that they encounter in their work. Peer workers face a lot of inequity within their workplace. They lack basic resources which are generally provided to most working professionals, such as a photo ID or a business card. They also get inequitable pay compared to other workers without lived experience of substance use, despite the similar work that they do. Many peer workers also feel that they are not respected by other professionals, such as police officers, paramedics, and others. This lack of respect may be due to societal stigma that sets to define peer workers solely by their history of substance use, rather than recognizing them as working professionals. There is also lack of awareness about the important work done by peer workers in overdose response settings.
One of the interventions that was implemented under the recognition arm of the ROSE model were photo IDs and business cards for all peer workers at the pilot sites. Photo ID and business cards are popular tangible symbols of professionalism, authority, and validity within a role. The fact that peer workers often do not have them is indicative of the overall respect for their roles. Photo IDs can be a visual reminder of peer workers' importance within the organization and prevents the risk of them being unnecessarily questioned by those unsure of their role.
Another intervention that was implemented as part of the peer-to-peer project was the creation of a video titled #PeerLife, which features a day in the life of four peer workers. This video is centered around the idea of creating awareness of the work done by peer workers in order to address the negative attitudes towards them. I am proudly featured in this video, as well as myself and Kat with the song that we both wrote and sang for the video itself. We are now going to play the shorter version of the video for you. So we hope you enjoy it.
Uh-oh, we're having some tech difficulties, so we'll try and play that at the end of the presentation, but we'll keep going for now. So in addition to the interventions implemented under the recognition arm of the ROSE model, we recently launched an anti-stigma campaign titled Compassionate Action. The Compassionate Action modules are a series of interactive case study videos about stigma and discrimination experienced by people who use substances. The videos are based on real-life experiences of people who use substances. Each video has an accompanying facilitator guide, or we can call it a discussion guide, and the modules are intended to bring the people who use substances and other providers together to encourage collaboration and mutual respect. Module 5 of the Compassionate Action series features the experiences of peer workers with other professionals, such as police and paramedics. We acknowledge that many police officers respond differently to those in the video and have taken important steps to implement techniques and approaches to better work with peer workers. However, often these negative experiences are shaped by past negative experiences. So in order to improve interactions in the future, steps are necessary for both peer workers as well as police officers. Police officers can focus on creating an environment of safety and comfort through reassurance and acknowledgement of the life-saving work done by peer workers. And in turn, peer workers can actually respect and recognize the work of police officers to maintain the safety of the public and the paramedics. We have included a link to the module in the chat box and encourage everyone to have a look at your own time.
The stigma and inequity faced by peer workers cannot be changed overnight. It is our collective responsibility to work collaboratively and to help improve the experiences of people who use substances. We hope that our presentation has been informative and useful.
We would like to end by acknowledging our research teams based in Victoria, Vancouver, Maple Ridge, and Coquitlam. Thank you.
And if you need more information about our project, I've included the links here for both the long as well as the short version of the #PeerLife video. Module 5 of the Compassionate Action series, and all other resources developed by the peer-to-peer project. And if you have any questions or ever want to reach out, I've included our key contacts as well. I will leave the video for the end after Amiti's presentation if we still have time. Thank you so much.
Thank you very much. And now we turn to our final presentation from Amita Mehta, which will take us into the realm of police response. Amity, please take it away.
Hi everyone. Thank you for the introduction, Scott. In this presentation, I will be discussing the police notification and attendance at overdose events following a provincial policy to not routinely inform police of 911 calls for overdose. This analysis is led by the BC Centre for Disease Control in collaboration with the BC Emergency Health Services. Next slide, please, Sarah. As my colleague Jessica has already talked about an increase in the opioid overdoses in BC and bystanders at overdose events feeling reluctant to call 911 due to fear of police involvement. In BC, the intake and the assessment of overdose, intake and assessment of the emergency calls are seen by the BC Emergency Health Services. So whenever someone calls 911, the medical call taker assesses the severity of the situation and then assigns an appropriate first responder. Therefore, to overcome this concern of bystanders delaying or not calling 911, in June 2016, the BC Emergency Health Services introduced a policy. Next slide, please. So this policy included to not routinely inform police in the event of an overdose in order to decrease the police attendance at overdose events. Police, however, are still informed in cases of death, attempted suicide, or where there are safety concerns for public or for first responders. Next slide, please. So the purpose of this study is to evaluate the effectiveness of this policy by the BC Emergency Health Services in achieving its intended outcome. That is to see if there is a decrease in the police notification and attendance at the overdose events. And BC is one of the first jurisdictions in Canada to have introduced a province-wide policy to encourage bystanders to call 911 at the overdose events. And through this study, we want to share the policy outcomes with other provinces who may be considering introducing a similar policy. The objectives of this study are to assess that after the policy by the BC Emergency Health Services was introduced, if there's a change in the police notification by the BC Emergency Health Services dispatch operation centers for calls that were determined to be overdose related, and if there's a change in the police attendance at the overdose events after the policy was implemented. Thank you. So in order to assess the police notification of the overdose events, we obtained the data from the BC Emergency Health Services Dispatch Center. So from January 2014 till September 2020, approximately 130,000 overdose calls were made. And then we did a descriptive analysis to assess the police notified overdose events provincially by month. Next slide, please. And this slide shows the results from the descriptive analysis. And here we can see that the monthly average of overdose events where police were notified of the overdose event declined from 47.8% in the pre-policy period to 18.5% in the post-policy period. And the graph also shows a decline in the police being notified of the overdose events in the post-policy period. Next slide, please. In order to assess the police attendance at the overdose events, we obtained the data from the take-home naloxone administrative forms returned to the BC Centre for Disease Control. So the BC CDC initiated the take-home naloxone program in August 2012, which aims to distribute the take-home naloxone kits to those at risk of witnessing or experiencing an overdose. So these administrative forms are actually included with the take-home naloxone kits or at the take-home naloxone distribution sites or online. So the individuals who administer these BCTHN kits are encouraged to complete these forms and return them back to BC CDC. These forms collect information with regards to the overdoses and overdose events, and if 911 was called or if police attended. So from program initiation till March 2020, approximately 4,500 take-home naloxone administration forms were returned to BC CDC, and then descriptive statistics and separate regression analyses were then conducted to assess this data. Next slide, please. This slide shows how the study sample for the analyses assessing the police attendance at the overdose events was obtained. And we can see that our final sample included 1,135 respondents who said that 911 was called at the overdose event and provided a valid response to the question about police attending the overdose event. Next. This slide shows the results from the descriptive analyses. And here we can see that overall, 40% of the overdose events which were police attended. And if we compare the pre and the post policy periods, we can see that the average overdose events that police attended in the pre-policy period was 56%, which declined to 38% in the post-policy period. So this slide, this table shows that compared to the pre-policy period, there's a decline in the police attendance at the overdose event in the post-policy period in all the health authorities. And if we look at the Vancouver Coastal Hall, the police attendance at the overdose event in this health authority was lower than the other health authorities in BC. And this finding is in line with the prior policy introduced by the Vancouver Police Department, which involved to not routinely respond to the overdose events unless requested by the emergency services. And this slide shows the results from their separate regression analyses. And here we can see that there is a decline in the police attendance after the policy by the BC Emergency Health Services was implemented, as the direction of the trend line appears to change when we compare the pre and the post policy periods. There are also some strengths and limitations associated with the study. One of the key strengths of the study is the corroboration of the findings between the two data sources. So the data from the take-home naloxone administration, the data from about the police being notified of the overdose events from the BC Emergency Health Services is corroborated by the findings from the BC take-home naloxone administrative forms. And also the data from the BC Emergency Health Services is obtained province-wide, so it's pretty comprehensive in nature. There are also limitations with this study. The data from the BC Emergency Health Services only talks about if police were being notified of the overdose events. However, it's unknown if police actually attended those overdose events. And there are also some limitations with the take-home naloxone administration forms, as the proportion of the forms returned to the BC CDC represent only a small proportion of all the overdose events in BC reported. Therefore, the findings could not be very generalizable. Also, due to inaccurate recollection of the overdose events, the findings may be subject to recall bias, and also the findings may be subject to social desirability bias, as during the take-home naloxone training sessions, the need to call 911 is often emphasized to the trainees, and therefore the respondents to these forms may often feel like that they need to respond by saying that 911 was called at the overdose event. Based on our results from our findings, we can conclude that the policy by the BC Emergency Health Services was successful in decreasing the police notification and attendance at the overdoses. However, we feel that further research is needed to determine if the policy was successful in increasing bystanders' willingness to call 911. I hope you enjoyed the presentation. Next slide, please.
I'm just asking in the chat whether what sort of for a pulse sense from our attendees, would they like to ask some questions or go and try and see the video if you've got that set up? When you shared your screen, did you check off the boxes for video, sound, and optimization?
I did, but I think the link got lost in the emailing between the participants, so that's fine. If we do have time, I can run it off of YouTube directly. Okay, but if there's questions, we're okay with that.
I'm not seeing, I can't see the, let me see if I can see the whole group. I'm not seeing anything in the chat. Why don't we try the video if you want?
Okay.
Okay, are you setting up the video and sharing your screen?
I am.
Okay.
For some reason, I'm unable to share my screen now. Am I not a panelist anymore?
You're still a panelist. It says all panelists. I don't know.
Okay, done. That works. Okay. Can you all see my screen?
Yes.
Okay.
Hey, baby girl. I love you. Hey, guys. Hey, good.
One-handed?
Yeah. My name is Denise Edwards, and I'm known as Grandma Coquitlam, Ma, Mom, or Grandma. I answer to all of them, and I'm proud to be a peer worker.
I became a peer worker just over 3 years ago. As a person, you know, that spent his life in prison and spent his life doing drugs, you know, I thought, well, what am I going to do for employment? Well, no one's going to hire me. And then this guy wants to hire me. And I said, well, what do you do? He said, we work with street people. And I thought, well, that's something I really know.
I'm a functioning drug addict, and I look around and I see my friends and even some of my family that have passed away and have overdosed and have caught different diseases, and I want to help. I've saved 72 lives up to date. I haven't lost one yet, and I don't plan on it.
Saving lives, you know, when someone comes out of it, you just feel elated, eh? It's like, whew, did a good job, eh? Shake the guy's hand, he smiles at you, eh? Or sometimes he'll just insult you. Yeah, so that cost 30 bucks, you just blew 30 bucks off me. But I know that's him in that moment, because I know next day he'll come over and thank me for, you know, for helping him out, eh? And that's the best. Someone just says thank you.
The biggest challenge is the stigma. People have this idea that any addict is a useless piece of poo-poo. And that's just not true.
When I go out on the street, I see people for people. Just trying my best to be a human being. That's it. There's no big glamorous thing for me. It's just, you know, I want to help people because people help me.
Here's that patience, understanding and drive. Wanting to help, the blessing is keeping people alive. We carry much on our shoulders, out there on the scene, on call day and night. Wanting no more lives lost in this harsh war. Decriminalizing and safe supply would make it right.
Thank you, and the music too. Tracy, thanks. Okay, so we still have 10 minutes. is it possible to make everybody show up now on the view so we can see everybody in the group, and to potentially have some questions live? Hannah?
Yes, I can promote attendees to panelists, and then they'll be able to show up.
Okay. Meanwhile, I would like to hear more about your thoughts about if the changes of COVID and the pressures of COVID I don't want to say, have we learned anything? Is there anything other than that we don't want to have pandemics coming out of this strange experience that's been added on to everything else?
I can speak. Can you hear me there?
Yes.
Yeah. Well, I can speak. I mean, you most likely have had similar experiences with your overdose numbers, but it's been a learning experience. You know, like our drug area. We basically had about 4 square blocks where was the high trafficking area where a lot of users congregated and slept outside and stuff like that. With COVID, what Victoria has done is they've set up a lot of the hotels and our big hockey rink into temporary shelters, and it had this real unforeseen response. They were trying to keep all these people safe, putting them all in hotels and hoping that the overdose numbers would go down, because at a lot of the sites, there were people actually designated to look out for their safety, to watch out for overdoses, naloxone being distributed. But the overdose numbers went up exponentially. They went up like crazy. And I think part of that reason is it was the COVID created this fragmentation of people. So as strange as it may sound, people had their own kind of peer safety systems, supports in place where they watched out for each other. Where yes, they were buying tainted drugs, but they were buying it off the same person for quite a while. So it was like predictable, you know what I mean? And so putting a lot of people into the hotels because of COVID-19, people lost their little support systems that they didn't even really know that they had. It just kind of fragmented everything, you know? That's what I noticed, anyhow.
Oh, that's really interesting.
Mm-hmm.
Questions? Lizzie or Carla, I see you're not muted at least. To what extent, I'm curious in terms of the system, to what extent has there been, you know, what's the funding situation like to support peer workers where you guys work? And sort of like the official, you know, recognition from the social services side.
From social services side, it's been better. It's been a little bit better. I actually work out of a social services office, so one day a week doing outreach. They've actually pulled us in and let us do outreach and had on harm reduction in the office. So it's a start.
That's good. Tracy, did you have a question?
Not really a question, just an observation. But certainly I'm from Scotland. It's a pleasure to be here with you all today, and I thoroughly enjoyed your presentations. I'm based on a research team at the University of Stirling, and we're doing a bit of work in terms of peer research and peer support for people who use drugs within homeless settings. And what we've found is that acceptance that peers are necessary and helpful, and that they can be skilled workers, and usually are very, very skilled people. It's growing, but there are pockets where people are reasonably well paid, could be paid better, but recognised for the important work that they do. And then there's other areas where it's seen as an add-on to the service. So maybe peers need to be there, but in a voluntary capacity. And I think it's really important to be raising awareness that no, peers should be well paid. And that actually this idea that peers are somehow less than, in my opinion, they're more than, and therefore should be appropriately paid for the work that they do and recognised for that. I think there's still a long way to go in tackling stigma.
How are relations with the police and between the police and the peers?
In Scotland, I would say very positive, because we have a lot of work ongoing in that area. But like anywhere else, it's not uniform. Do you know, it's not across the piece. There are pockets of really good practice, and then there's pockets where it could be better. I think we're on a good path, but there's more work to be done.
Is there an acknowledgement of the possibility of people being drug users and still actually managing to be contributing members of society? Or because we still have that gulf, like if you're using drugs, that's it. You're on the other side of some kind of divide. And you know, the stigma is really strong.
I think it depends. There's a lot more respect certainly for people who are in recovery, but there's still that distinctions being made, that idea that people in recovery need to have been in recovery for a certain amount of time, that's some kind of linear process. And then, you know, we don't have experience of working with peers who are still in active drug use. And maybe that's some of the shift that still needs to happen.
I think that's one of the differences between BC and other areas, including other provinces within Canada, is that recognition piece is still missing. And peer workers here some people are in active phase of using, and others are more so in the recovery phase, or some have recovered for a few years. So I think that recognition piece of including peer workers who are currently using as well as part of the workforce and being part of the overdose response environments is something that's super different and a huge step towards recognition of peer workers in society. And in terms of your previous note, Tracy, about the point of paying peers, BC CDC has a resource. It's a best practice guideline on paying peers, and it recommends that we pay peers based on the living wage and not just the minimum wage of the province. And I think that's a really important resource to share with you. So I'll include that in the chat box as well.
We also had a question as to whether you guys have noticed a difference in the demographics of the population you're serving since COVID.
When you say demographics, the biggest thing that comes to mind with me, our biggest challenge has been accessing the biggest percentage of people that are having fatal overdoses. Like here in BC, it's something like 80% of fatal overdoses are men between the ages of like 30 and 49, mostly male, living alone in a residence, right? And so often, you know, people think of substance users as just people on the street, but the majority of the fatal overdoses are people, you know, dying in their own apartments, condos, housing, right? And accessing those people has been the biggest challenge.
Thank you, Mike. And I've got to close now because of the way they run this conference on train tracks. But thank you all for a most enlightening presentation and a glimpse of a pretty comprehensive glimpse of this issue up from BC. So we'll see you all around the conference, and thanks to you and our audience.
Thank you,
everybody.
Thank you.
Thank you.
Thank you.
How did I get here?